Okay, so another complication can be hemorrhaging. So thrombocytopenia, or the reduction of clotting factor. So less than 50,000. Oh, darn it, I was going to look. Hold on. All right, well, I was trying to find out what the MM3 stood for. I did read something about microliters, but I don't think that that's it. So if anyone figures it out, let me know. So the textbook, the new 5th edition, says 75,000, not 50,000. So it looks like less than 75, so it's a little bit bigger of a number. Less than 75,000 mm to the third power, whatever that is, increased bleeding during debridement. And less than, so this is the platelet count, so this is a platelet count, less than 20,000 spontaneous bleeding. And then I read something just a second ago that said less than 10,000 spontaneous internal bleeding. So the numbers are, I guess depends on what you're reading. So the management, consult oncologists as to the patient's platelet count or their blood count. Trauma from improper brushing or ill-fitting denture could initiate bleeding. If dental procedures are imperative, platelet support therapy may be given by the oncologist. Salivary gland dysfunction and dental caries, dry mouth, thickened secretion, ropey saliva, or excessive drooling may occur during chemotherapy. Dental caries not specifically linked to chemotherapy, but rather chronic dry mouth and or increased intake from carbohydrates or poor oral hygiene. Management would be, nutritional counseling. Fluoride trays would be a big one. Staying hydrated would be a big one. Counsel primary caregivers, oncologists, and the family, and oral hygiene techniques and oral hygiene instruction. Radiation, head and neck cancers. Radiation of the head and neck. Radiation therapy uses ionizing radiation, either from an external beam or from an internally implanted source. Examples of cancers that get radiation therapy oftentimes are oral, oropharyngeal, lymphomas, salivary gland tumors. Lesions less than 1 centimeter may require just surgery or radiation, small and superficial tumors. Damage to normal cells may be acute and resolve after therapy. So as we know, all radiation is ionizing and has biological damage. But the more concentrated it is, and the more it happens in a short period of time, the more damage. If it's spread out, it gives your body a chance to kind of rebound and heal a little bit. Other normal cells may not be able to repair themselves, long-term complications. So salivary gland cells may not repair as well, so there might be long-term xerostomia. Complications: acute the first week after radiation, xerostomia, loss of taste, mucositis, dysphagia, secondary difficulty swallowing, secondary infection, trismus, kind of that feeling like you can't open your mouth, impaired nutrition, hearing loss, fatigue. Chronic complications could be xerostomia, altered taste, the telangiectasia. That's the spider veins, destruction of little blood vessels, so it creates spider veins. Friable mucosa, or it's just very fragile. It bleeds easily. Even something like the back of a toothbrush, if it's rubbing against very fragile mucosa, could rub a sore into it or cause bleeding. Continued fungal infections, osteonecrosis or soft tissue necrosis, that's a big ones for us to watch out for. Rampant caries, muscle fibrosis, TMJ disorders, and trismus. Altered tooth or jaw development, especially in young kids who are undergoing radiation. Surgery, primary treatment when the lesion is small, completely excisable without complications, not sensitive to radiation therapy, no involvement of the lymph nodes or salivary glands or bone, and reoccurrence of tumor after radiation. So those are when surgery would be a primary treatment. And as you can see, resection of bone and of the jaw for oral cancer can be severely disfiguring and life-altering. Complications are, of course, physical. There's infection issues, airway obstruction issues, fistulas, necrosis, osteonecrosis, impairment of swallowing, hearing, vision, smell, speech, compromised nutrition, ability to swallow, chronic, drooling, depending on what's happened to the shape of their mouth and their face after surgery, malocclusion, many teeth might have to come out, extracting many teeth, temporomandibular disorder, facial deformity, which can cause all kinds of psychosocial problems. I mean, dealing with your face, not looking anything like it did before and feeling deformed, can cause all kinds of just mental anguish, stigmatization, depression, anger. So management after surgery, management by the dental hygienist, assess for oral irritation and comfort, empathetically listening and helping with stress reduction. Oftentimes that's one of the biggest things you can do, is just empathetically listen and then try to make suggestions, even if it's a small suggestion, something very small that might improve their comfort. It would be deemed from their perspective as huge. Oral hygiene instruction, frequent gentle cleaning and hydration, irrigation with a syringe, saline rinses, cotton-tipped applicators for debridement, or a sponge swab and gauze. Prosthetics after surgery, we've been introduced to the obturator already for different things like oral facial clefts. Assess ability to wear a prosthesis, the shape of the oral cavity, the dryness of the tissue, the thinned or fibrous tissue, maxillary difficulties after surgery, the nasal voice quality, a thickened nasal or sinus secretion that might leak into the oral cavity, facial disfigurement, difficulty with speech, swallowing, eating, and then a surgical obturator might be necessary. And then mandibular difficulties after surgery may need additional surgical procedures to help attain function back so that they can actually maybe talk and eat and things like that. So bisphosphonates and osteoradionecrosis. So bisphosphonates, they alter the ability of the osteoclast to resorb bone, and they suppress bone turnover. So it increases bone's density. So this is obviously something that is desirable, but it can have side effects. So osteoradionecrosis has to do with the exposure of bone that won't heal over. And this can be a result of radiation therapy, or if there's something that causes an irritation or something like a surgery or something that takes place, and then the bone gets exposed and starts to necrose, and it won't heal itself and cover back over with soft tissue. So if it's bisphosphonate related, osteonecrosis of the jaw is a potential side effect of IV bisphosphonates. So a lot of times if there's any kind of oral surgery or anything that has to take place, if someone's going to go on IV bisphosphonates, that's done prior to. So prevention, complete all recommended dental work prior to treatment. Management, meticulous oral hygiene to prevent any kind of complications from infection. Professional maintenance, careful review of health history, vigilant EO-IO, ensure patients' understanding of the medication and the risks. Assessing our cancer patients' current oral status, health and dental history review, frequency of care, dental experiences that were painful, assessing all of that, interviewing the patient with a cancer diagnosis to understand their perception of the disease, their health beliefs, and what they what they're ready to go through or what they believe is important, coping strategies, social support system, and dietary habits. So just kind of getting an understanding of all those aspects and how you can be of help and how you can help them make some decisions that will help alleviate their oral disease and their overall discomfort. General dental hygiene care before treatment, referral from an oncologist, dental surgeries completed by at least 7 days prior to chemotherapy and immunosuppression. So if there's going to be extractions or anything major, it should be done at least a week prior to cancer treatments. Dental surgeries completed at least 2 to 3 weeks prior to radiation therapy. Psychosocial issues, collaborate and give patients some sense of control. That's always a big one. Feeling like everything's just spinning out of control in their life. Everything, all these horrible, scary things they have to go through that they don't want to. There's just a huge lack of control. So feeling like they're part of the decision, giving them options and that sort of thing. Education, the importance of long-term oral care, oral hygiene instruction and self-care, optimal before starting treatment, before tissue is compromised, and then of course always counseling for tobacco and alcohol cessation. General dental hygiene care before treatment, nutritional counseling, contributing to control of caries and periodontal disease and infection, counseling to have a low sugar diet, low acid forming diet, and oral retention qualities. So moisturizing, things that don't stick to in the vestibules or to the teeth. And then fluoride therapy or xylitol, things like that to help with caries, possibly fabricating trays for increased fluoride to help prevent caries. During treatment, all dental treatment finished before entering into cancer therapy, supporting the patient's needs, listening, helping them to feel like they're heard by an oral, by a healthcare provider. Showing empathy is such a huge thing. It goes such a long way just to listen and be empathetic. And then your patient's the expert. They're the ones that's living it. They're going through it. You may learn quite a bit from them. This is actually true for a lot of our patients with special needs, our patients with heart conditions and diabetes. They're the experts. They're the ones with it, not us. We're not the cancer experts. But we can share our little section of expertise about how to maintain health or improve comfort. Management of oral complications, mucositis and stomatitis, salivary gland dysfunction or xerostomia. The infections can mitigating and preventing infection, bleeding conditions, caries, trismus or TMD, soft tissue necrosis, and osteonecrosis. So knowing that those are all possible complications, looking out for them and preventing them. During treatment, dietary concerns, like we said, nutritional liquid substitutes, juicing vegetables, green juices, soft, bland diet, or high in carbohydrate liquid diets, small, frequent meals due to vomiting and nausea, just wanting to clean out the mouth consistently after eating, lack of eating related to depression and stress, or maybe going for the wrong things because everything is so hard and just something that makes them feel better, and sometimes sometimes just to get calories they have to eat anything that they can possibly tolerate, but trying to guide them to better choices as much as possible. Dry mouth, thickened saliva, taste dysfunction. Sometimes everything tastes like cardboard. I've heard patients say it didn't matter what they ate. The most luscious, wonderful thing before they went through cancer treatment, during cancer treatment, tasted like cardboard, and eating was, there was no pleasure in eating. Nutritional counseling, encourage a well-balanced low-sugar diet. Ulcerations, diet high in moisture, thin foods with liquids, frequent sipping of water while eating, topical anesthetic or something that's coating, and avoid irritating, hot, spicy, or acidic foods. After chemotherapy, most oral manifestations do resolve. Many experience chronic candidiasis or herpetic lesions. Necessary dental treatment only after consulting with an oncologist to assess their immune status, their pre-meds if they're needed, and the platelet support. And then after bone marrow transplant, after being released, they're still immunocompromised for several months. So bland, gentle rinse and consistent cleaning of teeth is important. Saliva substitutes or custom fluoride trays is important. Necessary dental treatment only after consulting with the oncologist. Assess their immune status, if they need pre-meds, and if they need platelet support. So that's after any kind of intensive cancer treatment. Elective services after full hematologic function can be up to a year after completion of cancer treatment. So a patient may disappear for a segment of time and come back and say, I was dealing with cancer this past year, and all of a sudden there may be cavities and periodontal issues and things like that. So just being ready to help them get back to health. After radiation, lifelong frequent dental visits for maintenance care, potential damage to salivary glands in the jawbone, caries, demineralization, osteoradionecrosis are all things to consider. Fluoride trays, especially if they're dealing with xerostomia, consistent caries after other therapies, 2 weeks, chlorhexidine regimen, in-office fluoride varnish, nutritional counseling, and always thorough EO-IO, for especially a patient who's had any type of cancer. Their oral cancer risks go up. And then these are the guidelines for our clinic manual, dental management of patients with cancer, undergoing chemotherapy and radiation, possible antibiotic premedication required, consult their physician, control spontaneous bleeding with gauze, topical fluoride for caries prevention, xerostomia management. If they're in radiation treatment, use soft toothbrush, chlorhexidine rinse, topical anesthetic, rinse prior to eating if they're experiencing great pain, managing xerostomia, fluoride treatment, and managing any fungal infections. And that's it.